You know this slide, the first presenter showed us. I don't want to go into the details. However, please treat my presentation as a kind of remarks, some warnings about not ideal parameters which used to our daily practice. Consider that we really assess in our daily practice only epicardial arteries. Therefore, we have to take into consideration with accepting the results of these parameters that they are influenced by other parts of coronary bed. This is a merit of so-called European fathers of physiological assessment of coronary stenosis, Nico Pilse and Nico De Bruyne. But I would like to show you how we simplify these very difficult equations. So first of all, we assume that resistance is not important. Based on that, we calculate a ratio distal to proximal pressure during the hyperemia. This is most important thing, and then part of my presentation. However, we have to take into consideration all what was presented during second lecture, because without a proper measurements of hemodynamics, we'll get bad results not responding to the real situation of the patient. This is our responsibility to do that properly. This is very, very important. I don't want to go into these details because it was already very nicely presented. In terms of pharmacologic hyperemic agents, they are a lot on the markets. The last one, this is regadenoson, but to be honest, in a daily basis, we are accustomed to use adenosine. Some words about access, intravenous or intracoronary. There are various papers on that. However, we know quite well that for left main problem, we need infusion, intravenous infusion. For the rest, the boluses are equal to that. In terms of doses, we have to also remember. I'm a little bit curious on this presentation that 100 micrograms is enough for right coronary artery and 200 for left. I don't agree with you with this, because if you look at this slide, you see very clearly that there is a dependence between the dose and results. You can increase the percentage of positive results when you increase the dose. So please, every single time after these basic 100 and 200 micrograms, let's say add at least, let's say increase, let's say 100%. So this problem I have already mentioned about intravenous and intracoronary. I don't want also to go into the details how important this area of vascular perfusion, how important is a collateral circulations, and then the different, let's say, vessel length and per centimeter stenosis. But please take care that for your understanding of the needs for potential revascularization of the patient, you have to take these facts into consideration. Why? Because sometimes you have circumflex artery in a complex distal left main, which is relatively small, and you have with a significant stenosis, and then you have negative FFR results. So the question is whether you should treat or not. Just take into consideration the area of distribution. This is very important. The other story is that this concept of FFR gives us some simplifications and assumptions that everything is very, very, very easy. But we have to consider there is there is a very important moment and function of microcirculation which we not assess during the FFR measurements. So therefore, take into consideration that these results are not ideal. Sometimes, even with, let's say, tough stenosis, we have surprisingly not very low FFR measurements. So in terms of cutoff criteria, of course, 0.8 for FFR seems to be generally accepted. However, we have to remember that the concept of FFR measurement started almost 30 years ago, was tested for 1 and 2 vessel disease cases. Therefore, we have to consider this 0.75 for 1 vessel disease, for left main and multi-vessel disease, rather 0.8. However, remember and consider so-called gray zone, because you don't care for 1 vessel disease, this problem, but for very complex coronary artery disease cases, you have to consider this fact that deciding to perform PCI or to send patient for CABG or not. We have to remember that the value for 1 and 2 vessel disease are valid for more than 10 years. Here you can appreciate 15 years results. It's still clinically important. This method safely let you defer the revascularization in the patients. Also in FAME patients, in FAME1 patients, where we assessed multi-vessel disease, this concept works, and it's worth and valid at least for 2 years. However, due to all of these limitations for FFR measurements, non-hyperemic measurements of coronary stenosis severity came to the findings, and let's start what we do, what we can offer in a daily basis for our operators. First, we a little underestimate PD to PA as let's say parameter. It's very well validated also with FFR. Here you can appreciate correlations, distribution, and how this predictive value 0.92 was assessed. However, in today, due to a lot of papers published during last 5-6 years, the data on IFR, this resting diastolic distal proximal parameter, is very attractive. So you have here that the correlation with FFR is really very high. We have to remember that the cutoff criteria are different. I don't want to go once more to the gray zone problems for both of these indexes. However, this concept, similarly to FFR, works in a practice basis for PCI patients. We know the results of 2 big trial, Defined Flare and IFR Sweetheart, where was shown that the results are comparable. However, we have to remember that the concordance of these 2 techniques is not so high. We have to remember that there are these additional parameters which influence these results and discordance between these two parameters. Therefore, also the concept to check this by coronary flow reserve impact of macrocirculation. Not only from this slide, that this influence is much weaker for IFR than for FFR. So might be it should be also considered from clinical point of view. We know quite well clinical subpopulations where this discordance is higher. We also should take this into consideration for individual patients, taking into account the whole clinical scenario, not just only digits received by the measurements. IFR, which seems to be very attractive, checked in much more papers, clinically validated, but it's also the problem of this gray zone. We already know that for specific subset of patients, we should think and not as a general 0.89 cutoff criteria, but we should know this table taking into account, for example, discordance with FFR. RFR, this is resting full cycle ratio, the other non-hyperemic parameter, very well correlated with FFR. This is also available now by Abbott. DPR, this is diastolic pressure ratio, also works quite well and it's comparable with FFR. We know this slide very well. The paper of Van der Ver showed us that probably all of these parameters are very similar. We can think about a class effect of these parameters, but don't forget about old good PD to PA index, because it also correlates very well with IFR, so we can use it clinically. Very good papers showed us that probably we underestimate the potential value, clinical value of PD to PA might be there also similar, it could be exchangeable for clinical scenario. And just to conclude, we know quite well that from a clinical perspective, we have situations where one index can be a little bit superior to the second, but this is very hard to tell this right now, because in my opinion, right now we have much more facts, arguments that IFR should be our first choice. However, we shouldn't forget about FFR, just for example, trying to assess these gray zones.